From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to our listeners around the world. You're listening to the JAMA Clinical Reviews podcast. Thanks for being here. I am Dr. David Simel, JAMA Associate Editor and Professor of Medicine at the Durham Veterans Affairs Medical Center and Duke University. In this podcast, we will be discussing immune-thrombotic thrombocytopenic purpura, which I will refer to as iTTP. I'm joined today by Dr. Allyson Pishko, who is an Assistant Professor of Medicine in Hematology Oncology at the University of Pennsylvania Perelman School of Medicine. Dr. Pishko is the lead author of our narrative review on iTTP in the May 19, 2025 edition of JAMA. Dr. Pishko, thank you for joining us today.
Thank you so much for having me, Dr. Simel.
Well, Dr. Pishko, you described iTTP as a life-threatening thrombotic microangiopathy that presents with microangiopathic hemolytic anemia and thrombocytopenia. What are thrombotic microangiopathies and what makes them life-threatening?
Great. So thrombotic microangiopathies really refer to a pathologic diagnosis where we see diffuse clots in the microvasculature, so in the arterioles and in the capillaries. So thrombotic microangiopathies, we really can be diagnosed off of a biopsy, like a kidney biopsy, where you'll see diffuse thrombi in multiple areas. Of course, in some of these thrombotic microangiopathies, we can't wait for a biopsy or the affected organ is not easily biopsiable. And so we really rely on clinical features of thrombotic microangiopathies. And those clinical features are microangiopathic hemolytic anemias and the presence of thrombocytopenia. So with a microangiopathic hemolytic anemia, what you are seeing are shearing of the red blood cells as they try to pass these occlusions or clots in the blood vessels. And so that shearing can be seen on a blood smear where we will see red blood cell fragments called schistocytes. We also see signs of the red cell breakdown by seeing signs of hemolysis with elevated lactate dehydrogenase or low haptoglobin, and then we will see elevated indirect bilirubin levels as well. How this process is life-threatening is these microvasculature thrombosis can really occur in critical organs, such as the heart, where we'll see myocardial ischemia, or they can occur in the brain, where we will unfortunately see strokes. And so they must be treated very promptly to avoid these serious life-threatening complications.
When you have a patient with thrombotic microangiopathy and microangiopathic hemolytic anemia, how do you actually make the diagnosis of iTTP?
Really good question. So first, determining that this microangiopathic hemolytic anemia and thrombocytopenia are present, and then we're running our differential of what could be causing this. And so TTP is a rare diagnosis where it's present in 3 to 6 per million. And so we always think about more common etiologies of a thrombotic microangiopathy. So things like disseminated intravascular coagulation, which can occur when there is severe sepsis present, or there can be patients who have had a transplant, a bone marrow transplant or a solid organ transplant, where some of their medications or graft versus host disease may cause a thrombotic microangiopathy. So we kind of think about some of those more obvious or common etiologies for the presentation first. And then, if none of those are present, really what is going to define the diagnosis is the presence of severe ADAMTS13 deficiency. So it's really obtaining that laboratory value where we see the ADAMTS13 activity be severely deficient that is going to clinch the diagnosis of TTP.
What is ADAMTS13?
So ADAMTS13 is an enzyme that typically is responsible for cleaving large multimers of von Willebrand factor. So von Willebrand factor is secreted by endothelial cells, also platelets, and it's usually in a ultra-large multimer form. And you need ADAMTS13 to actually cut apart or cleave the large multimers to keep platelets from binding and to keep the blood flowing nicely through the vasculature. When you don't have ADAMTS13 present, you're not able to cleave these ultra-large molecules of von Willebrand factor. And so what happens there is these ultra-large molecules of von Willebrand factor accumulate and they bind platelets and can actually lead to the occlusions of the blood vessels and the thrombotic microangiopathy.
Is iTTP the only example of a microangiopathic hemolytic anemia where ADAMTS13 is low?
So ADAMTS13 deficiency, when it's severely low, and we usually use a level of less than 10%, really defines the diagnosis of TTP in a patient with microangiopathic hemolytic anemia and thrombocytopenias. Now, there are two types of TTP that can occur. There is congenital TTP, which we didn't focus on in the review, but is actually an inherited, even more rare disorder where you have congenitally low ADAMTS13 levels. And then immune TTP is where you have an autoantibody to the ADAMTS13 that results in either ADAMTS13 being cleared or the function of ADAMTS13 being inhibited. So once you have the ADAMTS13 level back, where you are identifying that you have severe deficiency in ADAMTS13, the lab will reflex to look to see if they can actually detect an antibody to ADAMTS13. So the antibody to ADAMTS13 being present really is defining for the diagnosis of an immune thrombotic thrombocytopenic purpura.
Well, you described a dramatic change in survival from close to 0%, where almost everyone died, to 93% survival for iTTP if the patient gets rapid treatment. But to get that rapid treatment, you want to know that they actually have the disease you're treating them for. And I can imagine that in most parts of the world, the ADAMTS13 is not readily available. So what do you do in that situation when the lab result to confirm the diagnosis isn't available and you need to treat rapidly?
Really good point. Yes, this is you do not wait for the confirmatory lab test type of diagnosis because, as we mentioned, this can be a rapidly fatal diagnosis. So what we can use is actually clinical laboratory features that are readily available and some information about the patient to determine the likelihood of that patient having severe ADAMTS13 deficiency. There are two scores that have been developed, one of which is the plasmic score, which has been validated for patients who do have a microangiopathic hemolytic anemia and thrombocytopenia where there is a suspicion for TTP. And what that is a 7-component score that looks at the severity of the platelet count, being less than 30, being more indicative of a diagnosis of severe ADAMTS13 deficiency. It looks at the INR, which is a measure of the blood clotting, and that should be close to normal. And it looks at other features like the lack of an advanced cancer diagnosis or having had a solid organ or bone marrow transplant. And it uses those features to come up with a score that is the likelihood of that patient having a severe ADAMTS13 deficiency. So with that score, it's a total of 7 points. When people have a score of 5 or more on the plasmic score, it is recommended to send off that ADAMTS13 testing, but to consider initiation of empiric plasma exchange and other therapies for a diagnosis of TTP, recognizing that, as you mentioned, in many institutions, this is a send-out test. It's not going to be back for a number of days, or even when institutions perform it in-house, it is something that is typically run during business hours. And because this is a rapidly fatal diagnosis, it's recommended to treat while awaiting that confirmatory test. And scores like the plasmic score can help you to make decisions regarding that.
Well, the disease is a deficiency of ADAMTS13, and the rapid treatments you described that were all that we had available until most recently are plasma exchange, corticosteroids, and rituximab. What do those things actually do to the ADAMTS13?
So the backbone of therapy, as you mentioned, has been therapeutic plasma exchange, and that is the one that we're generally trying to initiate right away. And what that therapy is doing is actually removing the patient's autoantibody to the ADAMTS13 and replacing it with donor plasma, which donor plasma gives the patient back ADAMTS13. So you remove the antibody and temporarily give back the ADAMTS13 via donor plasma. And so that plasma exchange is really a temporizing therapy. You have to insert an apheresis catheter for the patients to have this therapy. It's something that is done daily for the initial treatment of TTP. And then we know that in patients who have immune TTP, which are going to be the vast majority of adult patients who are diagnosed with TTP are going to have the acquired or the immune-mediated form, that we don't just want to temporize them with the therapeutic plasma exchange, but we actually want to get at the root of the problem, which is the autoantibody to the ADAMTS13. And so that is when we use immunosuppressive therapies. So the quickest acting, the one that we start right away, are corticosteroids to decrease the production of the ADAMTS13 autoantibody. And then it has been shown that rituximab, used in the first line for patients who do have immune TTP, could also be added to therapy to hopefully reduce that autoantibody production and decrease relapses of TTP. So first, therapeutic plasma exchange together with steroids, and then with confirmation of the diagnosis, the addition of rituximab has been the standard first-line therapy for TTP.
How much of a concern is bleeding when you place the catheters for the plasma exchange?
Generally, as we mentioned with TTP, the thrombocytopenia is moderate to severe, so it generally is less than 30,000. So that bleeding certainly can be a concern. Fortunately, the catheter insertion is a pretty low bleeding risk procedure, so we generally do not recommend transfusing platelets prior to the insertion of the catheter. Of course, that depends on if the proceduralist is comfortable doing that, and if the most important aspect of this whole therapy is getting the plasma exchange done promptly. So platelet transfusion, if necessary to get the apheresis catheter in, can be done, but is generally not needed prior to the insertion of the catheter because it is a low-risk procedure. But certainly there are other risks of placing an apheresis catheter. Some of the things that we can see when we are performing therapeutic plasma exchange can be related to the actual procedure, lung puncture, but doing that, usually we try to do it as an internal jugular catheter insertion. We generally, if the line is left in place, which it needs to be until patients are responding to therapy, there can also be increased risk of infection, and you can see, thrombosis with the catheters. So that's why, as we talked about, it's so important to use these clinical prediction scores. We certainly don't want to do too many of these procedures when they're not truly necessary, but we also need to use these clinical prediction scores that are sensitive enough, which the plasmic score has been well validated, so that we don't miss diagnoses and we aren't withholding plasma exchange when we should be doing it.
So the three arms of treatment have been plasma exchange, corticosteroids, and rituximab. But you've now described what I'm going to take the liberty of calling the fourth arm of treatment, and you tell me if that's okay, in using the medication Caplacizumab. Tell us about Caplacizumab.
Yeah, so these are all therapies that are now, considered in the first line for a TTP, but I think it's fair to call it it was the fourth one to be out there, and it's actually our first FDA-approved drug therapy for TTP. So Caplacizumab was approved in 2019, and what it is it's actually a nanobody, or a very, small antibody that binds with high affinity to von Willebrand factor and a specific part of the von Willebrand factor, the A1 domain. And because it binds so well to that part of the von Willebrand factor, it can actually block binding of the platelets to von Willebrand factor. So you still have with TTP these ultra large von Willebrand multimers that are in the vasculature, but they're not able to bind platelets and cause the occlusions because of the fact that the Caplacizumab is there blocking that interaction. So Caplacizumab was studied together with a therapeutic plasma exchange and immunosuppression in the first line therapy of patients with confirmed TTP or with a high suspicion for TTP. And so it's generally administered the first treatment before the plasma exchange and then continued actually after the plasma exchange is able to be stopped till that ADAMTS13 recovers. So it is an exciting advance in TTP. It does work very rapidly, and so time is very critical when people have an occlusion in a life-threatening organ, right? We want to get that perfusion of the blood as quickly as possible, and Caplacizumab works very quickly. And so one of the outcomes they looked at for the trials of Caplacizumab was time to platelet normalization, or the platelets coming into a normal range. And that was, thought to be a good endpoint to look at, thinking that, this is the primary goal is avoiding that binding of the platelets to von Willebrand factor and hopefully preventing further thrombotic events.
So you mentioned a platelet response. What is the actual case definition of a clinical response, and what is it that you're following? Is it just the platelet count? Is it the ADAM TS13 levels? Is it the clinical findings? What goes into judging that the patient is responding?
The patients are typically initiated on, daily plasma exchange, and there's steroids, Caplacizumab and rituximab. And what we're monitoring is actually their daily platelet count, and then also we're looking at their lactate dehydrogenase levels as a marker of improving hemolysis. And then we're also looking at the patient clinically and making sure they're not having any signs of ongoing ischemic injury. So generally, plasma exchange is going to be continued until we see response of the platelet count into, a greater than 150,000, and that response should be sustained. And sustained has different interpretations from different centers, but generally like a couple of days at a normal platelet count, and then plasma exchange is discontinued. And then in the centers where they have the ADAM TS13 available, you can use the ADAM TS13 recovery to then measure and see if we can, decrease the immunosuppression. Most commonly, we're decreasing the steroid. You want to, rapidly taper it given the toxicities of steroids. And generally with the rituximab, you're doing a standard course of rituximab, which would be once weekly infusions for 4 weeks. So you're seeing the response to the plasma exchange, stopping the plasma exchange therapy first, using either your clinical markers or ADAM TS13 testing to determine if you can wean down your corticosteroids. And then with Caplacizumab, and I mentioned that therapy is continued after plasma exchange. It's something that is administered subcutaneously after plasma exchange. And there have been studies looking at using the ADAM TS13 level to guide when you should discontinue it. So if ADAM TS13 is over 10-20%, maybe a sign that you can come off of the Caplacizumab. By the labeling, the drug is continued for at least 30 days following the stopping of the plasma exchange.
Does the patient stay in the hospital for the full 30 days of rituximab treatment?
Generally, why, it's important to know what clinical response is because that's generally when we're, stopping the therapeutic plasma exchange. And usually when people are safely off the therapeutic plasma exchange, meaning they've stopped the plasma exchange, we don't see that their platelet count is dropping, that is usually when they're discharged from the hospital. And then the course of rituximab or Caplacizumab can be continued as an outpatient. Of course, the timing of things of when patients should be discharged really depends on each institution and the availability of laboratory testing and the patient's ability to come back in for those laboratory testing and treatments. But usually it is when therapeutic plasma exchange is stopped is when we're thinking about discharge.
Well, once you get a remission, and let's, for convenience, say a normal platelet count and a normal ADAM TS13, does iTTP stay away?
iTTP, unfortunately, can come back. So the highest risk time is within 30 days of stopping the plasma exchange or stopping the Caplacizumab. And why that is because you could still have severe ADAM TS13 deficiency because those treatments are not, targeting the immune system. That's where the rituximab and the steroids come in. So until you get this suppression of the autoantibody and the recovery of the ADAM TS13, you're still at risk for these early recurrences, which we call exacerbations. And then, like you said, once you get into remission, which it's been defined as at least 30 days of being off of these therapies, the plasma exchange or Caplacizumab, unfortunately, the iTTP, like many other autoimmune diseases, can come back. And so patients can unfortunately have relapses. Most of those happen in the first couple of years, but we have taken care of patients who have gone 10 years between their episodes. So it's really, really important once a patient has survived an episode of TTP to counsel about signs and symptoms, having petechiae, unusual fatigue, fevers, abdominal pain, that they need to really seek prompt medical attention and have laboratory testing because this diagnosis can come back.
Well, is there anything else you would like our listeners to know about iTTP?
Yeah, so I think we hit many of the high points that even though this is a rare disease, it is one where we have life-saving therapy. So really prompt initiation of therapy is needed when you have a high clinical suspicion. We also know that there's an evolving role for monitoring ADAM-TS13 for patients in remission and using actually preemptive rituximab to prevent those relapses that we were talking about. Another point that we didn't touch on today is that survivors of TTP seem to have increased morbidity and mortality outside of TTP episodes as well. Particularly, they seem to be at increased risk of cardiovascular events, including myocardial ischemia and strokes. And so those are really important things for internists taking care of patients with TTP to recognize. And why that is and what we should do about it is definitely an evolving area of important research.
Well, thank you, Dr. Pishko, for joining us today to talk about iTTP. I am Dr. David Simel. This episode was produced by Daniel Morrow of the JAMA Network. You can find a link to this manuscript in the episode show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.